Welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Sangeeta Krishnan, and I'm delighted to have with me today Dr. Cara Bossley. Dr. Cara Bossley is a consultant in pediatric respiratory medicine at King's College Hospital. Welcome, Cara.
Hello, thank you for inviting me.
It's a pleasure to have you. So I just wanted to ask you about asthma, especially asthma in children. So to start off with, what's the prevalence of asthma in children and young people in the UK?
It's the most common long-term medical condition in the UK in children, and about 1 in 11 children or young people have asthma in the UK. That's equivalent to around 1.1 million currently who receive treatment in the UK. So it's a really big burden.
Do you feel like the prevalence of asthma is increasing in your experience? And why do you think that is?
Looking at all the studies that have been recently published, it seems that the prevalence seems to have flattened slightly. There has been a previous increase, but now it's sort of flattened more recently. Looking at the UK data, the rates of emergency admission for asthma are actually decreasing slightly. But however, we have the highest death rates in the UK for asthma. And therefore, it's a really serious condition. And as it's so common, a lot of people forget how serious the condition can be.
Yeah, we have been seeing quite a lot of cases in the media. So I'm quite surprised to hear that the cases are not as high or they're dropping. But why do you think that the cases or the mortality is so high with asthma in the UK specifically?
There's a really big link, and we'll come on to this later, with social deprivation. And I think with the recent issues with people struggling more and more recently, I think social deprivation is increasing. This really links into childhood asthma. The other thing is that asthma is so common that people are sometimes less worried about it because it's so common, and they don't realise how dangerous it can be. And I think it's really important that we take this condition seriously and monitor and diagnose people with asthma effectively.
That's interesting. And speaking of deprivation, there have been studies that show a link between fruit intake and asthma risk. What's the link between healthy eating and asthma, Cara?
Yeah, it's a really important issue, and this has been studied in quite a lot of depth. And the first early studies looking at asthma and food intake showed that a Mediterranean diet was really protective against asthma acquisition and also the severity of asthma. And this has been shown, replicated in large studies. There's definitely a signal there. And then they've looked at specific foodstuffs, as you say. Specifically, they've looked at certain fruits, and we know that apples, oranges and bananas are really beneficial, and high fruit intake is protective against the acquisition of asthma and also the severity of asthma. And I think probably this links with the large number of antioxidants, vitamins and minerals that you get in fruit, and these then combat asthma, because obviously the acquisition of asthma is multifactorial. So the more antioxidants there are, the less likely you are to acquire asthma. But also in terms of asthma control, we do know that high intake of these fruits and antioxidants can protect you as well against exacerbations and attacks.
That's so interesting to hear. And also, you mentioned deprivation. So there must be so many other risk factors at play. So what other risk factors are involved in the development of asthma? What about climate change?
Well, first of all, with regard to social deprivation and childhood poverty, we know that that is a big risk factor for the development of asthma and continued asthma symptoms and severity. And Professor Ian Zinner has done a lot of work on this and published in a lot of journals about this and how important it is that we try and tackle social deprivation and childhood poverty, because we know that it's linked to adverse effects in asthma. And the reasons we think this is that there's poor access to the healthy foods. Obviously, they're more expensive. Fruits and fresh vegetables are often more expensive. and there's poor access in socially deprived groups. So therefore, they have less antioxidants in their diet. We also know that higher obesity rates link in with social deprivation, and obesity also is a risk factor on its own of asthma and poor asthma control. And the type of asthma in obesity can be slightly different and more difficult to treat. We also know that in areas with more social deprivation, there seems to be higher air pollution exposure, and air pollution in itself really can have an effect on both day-to-day asthma attacks, as we know, and also the acquisition of asthma. There is also a link between social deprivation and more passive smoking, and we know that passive smoking is bad for children and links to them developing asthma and also their severity worsening. This has been shown in a number of studies. It can affect in a number of ways. It can reduce the antioxidants in the body and cause the toxins from the smoke can trigger asthma itself quite directly, but also more indirectly. Smoking can also affect how well children respond to inhaled corticosteroids because it has a block on the steroid sensitivity there. We also know that children that live in poor housing conditions are more likely to be exposed to damp and mold, and they will be triggers for their asthma, for having attacks and also for developing asthma. And these groups are also have limited access to healthcare. It's more difficult for them to see a doctor straight away, and therefore there may be a delay in diagnosis, which will also have an impact. So it's really important that we try and address these issues at a more national level to reduce our asthma load across the UK. And then you asked about climate change. And this is also a big factor. So this in itself is a massive question, and we could spend an hour talking about climate change and the indirect and direct effects on asthma. But we know that climate change does increase air pollution levels, and higher air pollution levels will have a direct effect on producing more asthma attacks. We know when the levels are high, and we can all read our levels now, especially in bigger cities, we will notice that the number of asthma attacks are higher. And there's been a number of studies published to show this. It seems that also the change in climate related to global warming in itself contributes to the formation of ozone, which is actually a lung irritant. And this can then go on to obviously trigger attacks, but also worsen asthma control. And then the actual increase in temperature related to global warming can also give a higher risk of respiratory infections, different respiratory infections that we might not have seen in previous climates. And therefore, this can be a trigger in itself for asthma. And respiratory infections are often a trigger for asthma, even if these are viral or bacterial infections. And then climate change also can change the seasons. So it seems that global warming actually extends the pollen season, and therefore we're seeing, for example, children suffering from hay fever a lot earlier than we were, say, 10 years ago. And therefore they're the ones for children, obviously, allergen exposure is so important, it's so likely to be a trigger. This can trigger their asthma and cause them to have attacks or just ongoing poor control. And then on the other side of the coin, you've got the extreme weather conditions. And we have seen this in the UK, but obviously it's more poignant in Australia, where we've seen massive wildfires, whereby whole areas of the country have been engulfed in wildfires, and then smoke inhalation will cause significant irritation to the lungs, cause asthma attacks, and worsen any asthma control. And it must be really awful living in environments that are so smoky. And then we've got the floods and the storms, which also give higher exposure to pollutants. But also, as you know, thunderstorms can actually trigger some people to have asthma attacks. And it's really important that we know about those and that they're also aware of the risks of that. So all of these things together shows how global warming is having quite a large impact on asthma.
Interesting to hear how much of an impact it could have, just climate change and global warming can have on asthma. And what about genetics? If somebody has asthma, would their child be more predisposed to having asthma as well?
With regard to genetics and asthma, again, you could spend a whole hour talking about this subject. And it's really interesting that asthma's multifactorial. So you would have a genetic predisposition to asthma. This is more likely if you've got a first degree relative with asthma. Most stronger risk factor is a mother or father has asthma. So if your mum or dad has asthma, your child will often have a genetic predisposition to asthma. And then if they get a viral hit in infancy, i.e. a bronchiolitis, especially if they have a rhinovirus or RSV bronchiolitis, then they have a high risk of developing asthma. Now, if that child who had a genetic predisposition to asthma doesn't get a viral hit, it may be that they don't develop asthma. But we know that those children that do get that viral hit and have bronchiolitis have a much higher, around fourfold higher risk of developing asthma in later life, even developing preschool wheeze and then not growing out of that asthma. So we know that it's sort of multifactorial. If a parent has asthma, you are 3 to 6 times more likely to have the condition, but not all people that have a parent with asthma have the condition. And there are other environmental factors. So air pollution will also have an effect. Their diet, all the other environmental things that we've talked about will also add on in there. It's certainly not just one gene that causes asthma. There's multiple genes, and this is more of a predisposition rather than one gene means that they have it.
Interesting. And NICE has just recently published a new guideline in collaboration with Sign and BTS. So, what are the recommendations in this guideline about diagnosing asthma?
As I'm a paediatrician, I have just focused on the childhood part of the guideline. I do know about the adult part of the guideline, and it's based on this as well, just to focus on the child part of this. So the new guideline with regard to diagnostic is, I think, good. We're using much more objective testing now for asthma rather than going on diagnosis alone. But it's always important to get a really good history. So you have a good history and it's suggestive of asthma. Now we ask for a test to see if they have asthma. And the first test that's done is, if you have it available, is exhaled nitric oxide testing, fractional exhaled nitric oxide testing. And this is an easy test to perform for children. And they have that test as well as bronchodilator reversibility testing, spirometry. And then they're given a beta agonist, so salbutamol, and we see if there's a reversibility of 12%, so an improvement of 12%. And if either of those tests are positive and with a history of asthma, then we would suggest a diagnosis of asthma. So these are more objective tests. If, however, these are not available, then you can look at peak flow variability. This is not quite as good as doing spirometry, but if this is unavailable, then we would do that and then look at the amplitude of your variability. If it's 20% or more and there's a history of asthma, we would suggest a diagnosis of asthma. You would also consider doing some skin testing or blood testing to look for the blood eosinophil count and the total IgE to see if they're atopic. And then if they have a high total IgE and a high eosinophil count, then you could suggest a diagnosis if the other tests are not available. If they have high IgE but a low eosinophil count and the other tests are not available, you might want to refer to a specialist. In general, this is a more kind of organised route for the diagnosis. I like it, but obviously I am slightly biased in the sense that for me as a specialist, I have all of these tests at my fingertips. And I do think that it could be a challenge in the community if these tests are not available in the community.
And these are more specialist tests, or would you have access to them in primary care as well?
I think that it is variable across primary care. I think some of the tests are available in primary care. Certainly, peak flow is always available. For most primary care centres, it is possible to do a spirometry, and they're becoming more available in hub-like settings. And again, exhaled nitric oxide, most GPs have them now, but not all GPs. And obviously, that could be one that where you might not have it there. But possibly it means that you can build the resource around this, because I do think each of these tests are important. It might be a way to bid for these tests to be available in the primary care.
So, continuing on the BTS NICE and SIGN guidelines, they have recommended a combination therapy instead of the short acting beta 2 agonist monotherapy. So, what do you think about that?
Just to be clear, this is for the 12 years and above age. Previously, we would give a inhaled corticosteroid alongside a beta agonist, whereas now they have suggested the AIR treatment, which is as needed anti-inflammatory reliever therapy when the diagnosis of asthma is made in a child above 12 years of age. I welcome this change. I think that there have been a number of really large, well-conducted research studies that have shown that this approach reduces exacerbations in this group of people. It targets the inflammation in asthma, which is really good, and moves us away from these sort of over-reliance on beta agonists that have been in place for many, many years. It therefore, you tackle the cause of the problem rather than having a quick fix beta agonist approach. And one of the reasons for this is that, well, first of all, the trial data shows that it's better to reduce asthma attacks. So that's really important. But the second thing is that we know now that there is some danger in over-reliance of beta agonists. And if we overprescribe beta agonists, if patients are taking too many, they have a really high risk of asthma exacerbations and hospitalization, and actually also asthma death. Although it's rare, it is a higher risk in those that are on beta agonists alone. It's a dangerous approach, and we know now that it's an approach that we're trying to come away from. We also, I think the other good thing about using this approach is it helps with compliance issues. Previously, quite often people would forget to take the steroid inhaler in the morning and the evening, and they just grab the blue one when they need it. Now, what they grab is a dry powder device, which has both a long-acting beta agonist as well as an anti-inflammatory inhaled corticosteroid. So whatever you grab to take, you are taking a dose of both, which I think does help with compliance issues. So I think it's actually a really good way, good approach.
I know you probably already touched upon this, but how do you feel like these guidelines would change practice?
It's a good way to reduce down the over-reliance on beta agonists. I think it would change practice in the sense that we would need to ensure that they can actually take that dry powder device, obviously, because some people of 12 and above will find it difficult. And obviously, if that is the case, we would need to give more personalised therapy. I think it should hopefully make things more personalised, but I think it's a really good thing. As you know, if this is not effective, the kind of as needed anti-inflammatory reliever, then you would give a MART regime, which is using a combined device twice daily plus additional if as needed. That's your kind of step up after that. But yeah, I think it does change practice. It means we are less likely to give as much beta agonist with less reliance on that, which I think is safer.
That's good to know.
Yeah.
Do you have any other thoughts about the guideline?
Yeah, so the other thing the guideline tries to tackle, which previous guidelines have also tackled, is about monitoring and looking at contributing factors. And I think these are really important in asthma care for anyone with asthma. So it talks about trying to reduce smoke exposure and tackling that head on, i.e. specifically asking about smoke exposure. And certainly in our hospital clinic, we actually do have a CO machine, and we do test parents to look at their smoking and help to support them to give up. And obviously that's something that is really important in primary care, to try to help people to give up smoking where possible. And then also the other thing it talks about is looking at the inhaler technique. I know these are really basic things, but they're things that, if done well, can really have a huge impact on the person taking the inhaler. And then seasonal environmental factors. And then the other important thing about the guideline that I think is just to highlight is that the air regime is for the 12 and above, and for the younger children, if they're unable to use a dry powder device, we still use a MDI with a spacer, and it's always important to use that spacer device. Those patients would be still fine using that regime. So you would use a beta agonist in that regime of an inhaled corticosteroid using a MDI device with frequent monitoring, but also frequently check in if they can move up to the dry powder, because that is a more effective regime.
Yeah, that's interesting. You should mention the spacer, because we have articles or modules on asthma on MIMS Learning. And when we use any images, we are required to use one that shows the inhaler with a spacer, because that,
Yeah,
yeah, because very often, and it's surprising how much, if you're on the internet, how many of those inhalers are shown without a spacer. So, and that's when you realize that, and then people tend to use it like that as well, don't they?
yeah, all the time, all the time. And even in children that are being seen every 2 months for that asthma control, you think, well, they would have it right. We don't need to. But every time we go through it, and quite often they're not using a spacer, it's remarkable. So, you're absolutely right. Just always talking about it, and also looking at the spacer that they need. Quite often a child will turn up to clinic, oh yeah, here's my spacer, and they're 7, and it's a yellow one with a mask, which would have very little deposition on the airways. So you need to change them over to a mouthpiece so they get good deposition. And I think adults as well benefit from a spacer if they can't use a dry powder device. But I think now we are moving a lot more adults over to dry powder devices.
And speaking of inhalers, there have been data that say that inhaler emissions account for 3% of the NHS carbon footprint. And out of this, the propellant that's used in the meter dose inhalers, they contribute the most towards carbon footprint. So what do you think about that?
Yeah, this is quite correct. So there's very little carbon emitted from the dry powder devices. It's mainly, as you say, the metered dose inhalers which emit the footprint. So them changing the guidelines should help with reducing the carbon emissions. Asthma accounts for about 3% of the UK's carbon emissions, and it needs to be tackled. So I think the easiest way is to switch everyone from the MDI to dry powder device, and actually the NICE guidelines do support that. So that should help to reduce. But there are, in some cases, and it's quite topical here because we are talking, focusing on children as well, it's that quite often children can't tolerate a dry powder device. So we have to give them the MDI with the propellant inhaler. But we can still reduce their emissions by half by, for example, going from a 50 inhaler to a 100 strength inhaler. And that will cut your carbon footprint by half. It'll be also cheaper in the primary care because you're using half the number of inhalers, and also helps with compliance because quite often in a child that doesn't want to take their inhaler, they will only take one puff and not 2 puffs. So I am trying to reduce down that way. And I think it's still important to think about that. And then the other thing is about recycling your inhalers. So we're doing a scheme now at King's where people can bring along their inhalers to clinic. And I'm sure there's a lot of places in primary care where they can do this too. You can take your old inhaler and it can be recycled, and that will help with the carbon footprint. And then the last thing is about asthma control. So there's been a recent study published in Thorax by Wilkinson et al. That showed that poorly controlled asthma is linked to the greater carbon footprint. And the reason for this is the large amount of short-acting beta agonists used in those that are poorly controlled, and also the amount of healthcare resource utilisation. So it's really important to ensure that the patients have good asthma control, because that can also reduce your carbon footprint. Then the last thing that's important to know about in the primary care is about the asthma inhaler decision aid. And I really like this, actually. It's really simple, but really effective. And it was published by NICE alongside the new guidelines. And it's a kind of 2-page summary of what inhalers have more carbon footprint and what would be safe to do and what people can do to try to reduce the carbon footprint. And they can go to their doctor and say, is it possible for me to move over to this device because my carbon footprint will be less? And I think I really like that. But obviously the main thing is to keep people controlled with their asthma. So we should always put their care first. But I think these little things can really make a big difference on climate change.
Absolutely. And it's a work in progress, isn't it? So it's something that everyone has to think about on an ongoing basis.
Yeah, exactly.
And I just wanted to ask you, what are some of the red flag signs and symptoms of asthma in children?
The red flag kind of signs of suggesting asthma are things like wheeze from day to day, shortness of breath, which they have day to day, and then feeling very short of breath after exercise or after colds. And obviously asthma attacks that make them present to A&E will mean they quite often get oral corticosteroids. So if we can kind of prevent that, then that's better for the child and better for the admission rates as well.
And can you talk about some of the challenges that you'd encounter when managing asthma in kids?
There's still no cure for asthma. There's not a magic cure, which is a shame. All the medications that we use really are regimes which control asthma and help with asthma, but giving an inhaled corticosteroid will not change the natural history of the condition. We know that because there's been a number of studies that have looked at that. So we know that we need to give it to prevent horrible attacks and to prevent asthma death and to control symptoms to allow the children to lead normal lives. But we know that inhaled corticosteroids won't prevent progression of asthma. There's still no cure for asthma. And then the things that are really challenging in childhood asthma are the fact that for some children, it's really difficult to have to take an inhaler twice a day and to remember to do that, or to take it when they get symptoms. And it can really have a huge impact on how children are able to take part in sports, take part in PE activities, and getting them to school and continuing them at school. So these are all massive issues with asthma. It's a real challenge. I think looking to the future, there have been studies that have looked at biologics being more widely available. But in itself, I think biologics are quite invasive. They're expensive. They do affect the immune system. They are, in a sense, immunosuppressions of certain pathways. So it is a tricky one, but obviously a magic cure would be wonderful, but it's a very difficult condition to treat.
Do you think that there should be better access to biologics so children can be treated? Those who have asthma that's pretty severe.
This is still a high cost, I think, an invasive drug. So children with biologic therapy, they get an injection either once every fortnight or once every 4 weeks. And this will block part of the T helper 2 pathway for most of them. Obviously, omalizumab will block IgE. So there are, obvious side effects related to that because you're giving, in a sense, an immunosuppressant, but it is very targeted. And I think, therefore, it works very well. And certainly the patients we've had on it have gone from needing steroids every day or every other day to being able to wean off and just have this monthly injection. And now we're able to give some of our patients that are on, for example, mepolizumab, they can give their injection themselves at home, so they don't need to come into hospital every month to have the injection, which is great. And they're really well controlled. I think it should definitely be available for those with severe asthma. And I think it is difficult sometimes to get to those patients. And obviously, these are high-cost drugs, highly commissioned, that it can be more difficult. I think access in certain areas is better than others. Obviously, we're a tertiary centre where it's at our fingertips, but in other places in the countryside, it can be more difficult and patients have to travel a long way for those drugs. So I think, it should be more widely available and more known about as well.
Thank you for sharing that. And finally, I'd like to ask you one thing that you'd like for GPs to know most about.
Yeah, well, hopefully we've covered most of it on the podcast today, the new guidelines and some of the current challenges in asthma. But one of the things I suppose would like to just briefly touch upon, which we've not touched upon yet, are the kind of red flags that you would see in the community, which would precipitate a referral to a tertiary centre. I think it's really important that because you see so much asthma and it's your bread and butter, and it's really, you're doing a brilliant job with managing that. But it is important to look out for some of the red flags, which mean that it might not be asthma. And these are children that have a wet cough that doesn't go away. These are children that have had weight loss or have digital clubbing on examination, or those that have asymmetric wheeze is very rare and can be caused by a foreign body or sometimes even a narrow, significant bronchomalacia. And then those that have never wheezed and only have cough, again, is very rare in asthma. And it's really important that those patients are investigated more thoroughly. And then those patients that say that symptoms don't respond to therapy, don't respond to inhalers, and whatever you give them, it doesn't really make a difference. All of these patients, I think we should be probably seeing and taking a slightly closer look at and doing further investigations. And then those little babies that wheeze from birth, that's very rare in asthma, to wheeze from birth, and it quite often means there's possibly a congenital lung issue. And then those babies or smaller children that have a high respiratory rate at rest, all of these patients we should be looking at more carefully. We'll be more than happy to take any referrals for those patients.
That's great. Thank you so much, Cara, for those detailed responses. That was really very informative. I learned a lot today.
Thank you for having me.
Don't forget that you can claim CPD credits for listening to this episode. Be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further reading. Thanks for listening. This episode was produced by Jude Owen. You've been listening to the MIMS Learning Clinical Update podcast. Join us next week for another episode. See you next time.